We have about 1 hour to cover this topic, and once again, I have a lot of slides, so I will go through this fairly quickly. I've been told this morning that the slides will be converted to a PDF handout and posted on the Lynn University website, hopefully later today, maybe tomorrow, so you won't have to take the notes quite so much. So they should have told you about that this morning. But in any case, that's what we're going to do because they didn't give you paper handouts for the program. Now, today, in this lecture, I want to talk to you about the discovery of another attention disorder that is mistakenly being called ADHD, but which in many ways is markedly different from this disorder, and I think going to require a different approach to treatment than the kind of thing that we do for ADHD youth. So I'll bring you up to speed as best as I can. There was a whole special issue of a journal this month devoted to this disorder and this topic, and the literature is beginning to grow considerably about it and the many differences that exist between these two groups of individuals. Undoubtedly, you see these people in your practice, in your counseling, in your university or high school setting. You may have been calling them ADD or inattentive ADHD, but the research term, which I do not like, by the way, is sluggish cognitive tempo, and we are in the midst of trying to change that name even within the research journals. I'll have more to say about that in a moment. This morning I forgot to show you my sources of financial support for the previous year. I usually like to do that, as all presenters should, so that you can evaluate whether there's any potential conflicts of interest in the content of my programs. And I do speak for the pharmaceutical industry, most recently Eli Lilly, Shire, and Janssen. Okay, let's talk a little bit about the history of this concept, what we call SCT for the moment anyway. You may not be familiar with it, but the first reference to ADHD in the medical literature was not 1902, which was George Still's lectures. For many decades, we thought Still was the first to describe this condition. But 2 years ago, we discovered a medical textbook in German, and this textbook was by Melchior Weichert, and it contains a chapter called Disorders of Attention. And it describes beautifully, in rather colorful terms actually, what today we would call the combined type of ADHD. And you can even see here some of the things that were recommended, such as horseback riding, sour milk, the extract from the quinine plant, quinine itself that is, and others. So, but this is the first reference to ADHD in medicine. So the history of ADHD actually goes back now more than, or about 240 years. Alexander Crichton followed on the heels of Weichert in writing a medical textbook. He's a Scottish physician, and it turns out in our research on Weichert, we discovered that the two of them perhaps trained together. Indeed, Crichton may have been a student of Weichert's. And we suspect that because Weichert replaced him as the physician to the czars and czarinas of Russia at the time. Weichert was their court physician. Crichton begins to describe two disorders of attention: the traditional ADHD, sort of distractible, active, impulsive, talkative individual. But he also described a disorder he referred to as a weakened or diminished power of attention, in which the individual was lethargic, stares, daydreams, can't seem to concentrate for very long periods of time. This may be the first reference to SCT in the medical literature. We'll see. Then in 1968, we had the DSM, which basically focused only on the ADHD type of condition, and that continued through the DSMs, where we were focusing primarily on what people think of as the combined type. There was a period of time, however, where people were thinking that maybe there were two kinds of ADHD, ADD with hyperactivity and ADD without hyperactivity. And so back in the 1980s, people began to compare these two groups of individuals to see was there some meaningful difference between them. And the research was so mixed and so unpromising that by DSM-3R, they gave it up and moved entirely into ADHD. But people continued to study that non-hyperactive group, and I being one of them, and we began to notice that at least a substantial minority, perhaps as many as 30 to 50% of them, had a pattern of symptoms that wasn't like ADHD at all. They'd come in through an ADHD clinic, but they weren't hyperactive, they weren't distractible and impulsive and so on. What they were was very daydreamy, confused, lethargic, hypoactive, slow-moving, stares a lot, and also made a lot of errors in the work that they did. They seemed to almost be the opposite of ADHD, hypoactive, and not distractible, but stare a lot, and seemed to be very daydreamy, lost in their thoughts. So DSM moved on into DSM-3R and then 4, but people began studying SCT, as it was called at the time, in their own right. We began to go out and actually look for samples of people with these characteristics. Instead of trying to find people who were ADHD, we began looking directly for SCT. And at the same time, DSM-4 came back with its subtypes, and you know them as the combined hyperactive and inattentive. And then we found a lot of these kids and adults being called inattentive ADHD, as if there were 3 kinds of ADHD. What you may now know is, as of last May, DSM got rid of the subtypes. They don't exist any longer. And that was a good move, because there are no subtypes of ADHD. ADHD is a single disorder in the human population. On any given day, people may be more inattentive than impulsive, but just as likely a month or 2 or 3 from now to see a reversal in the symptoms. And in fact, with age, you can go through all 3 types of ADHD as you grow up. And because of that evidence that there really weren't any differences among these groups to speak of, the DSM-5 committee abandoned the subtyping. And now you can simply label them as inattentive presentation, but it isn't meant to convey something different. It just means that on this day, when I evaluated this patient, they were more inattentive than hyperactive, but it doesn't convey anything else. And again, I think that's a good move. But then what about this 30 to 50% of people being called inattentive ADHD who have this pattern of SCT? The DSM-5 was going to give them a place in the manual, and they were overruled by higher level committees who felt that it was premature to create another disorder given the small amount of scientific literature that was available at the time. A lot of us think that was a mistake, but I understand their desire to be very conservative at creating new disorders out of thin air and then be criticized by the press and Scientology and the public for being a little too cavalier in inventing disorders. But let's go through the literature that does exist now and see whether or not it might be a new disorder. Here are the conditions that have to be met for a new disorder to be invented. It has to be distinct across these various aspects of the literature. It has to have a distinct symptom presentation. The symptoms have to cohere. They have to correlate with each other. They can't just be a random mishmash of observations. We have to see statistically that symptoms correlate, form a uniform dimension. We have to see that there are different correlates in the psychological profile, the neuropsychological profile specifically. And do we find that these people have different causes, biological correlates to their disorder? And then so on down the list. You don't need me to read all of these to you, other than to say that these are the things we would be evaluating to answer the question, is SCT a legitimate disorder or not? And so that's what I'm going to do for you today. We're going to go through each of these areas and very quickly see what have we found here. And I think you'll be surprised because the answer is going to be probably. I can't say for sure. There's only about 60 papers right now on SCT, but they are becoming increasingly consistent and increasingly, I think, pointing in the direction of a second attention disorder. And by the way, there must be 6 attention disorders because there are 6 different kinds of attention mediated by the human brain. And so there won't just be one. ADHD happens to have been the initial one that was discovered, probably because it's so disruptive, but there will have to be others. And this appears, I think, to be the second. And by the way, one last thing, it's just a pet peeve of mine, but people often ask that, well, if ADHD or SCT are not categories like pregnancy, but they're dimensions of human traits, then when does a person qualify for a disorder? If we all share these traits, which we do, We all have executive functioning. ADHD is just the lower end of the Gaussian bell curve. At what point along that curve, along that dimension, does a disorder begin? And Wakefield answered that for us more than a decade ago, when harm is posed to the individual. Disorders begin where impairment begins. So let me just take a moment and make a distinction that's often not made in clinical practice, but it's very important, I think, both in practice and especially in science. There are symptoms and then there's impairments. They are not the same. I often hear people say, oh, he got a low score of that test. He's impaired in working memory. No, he isn't, right? Those would be aspects of symptoms. They might be deficits, but they're not impairments. So here's the difference. A symptom is the cognitive or behavioral expression of your disorder. Distractibility, for instance, not paying attention at school. That's a symptom. Speeding with a motor vehicle. That's a symptom of adult ADHD. Then what's an impairment? It's the consequences. It's the environment kicking back. It's what happens to you when you act that way. You lose friends. Your grades go down. You don't finish your academic papers. You have more car accidents than other people. You lose your license more often than others do. That's the environment kicking back. So, impairments are consequences. Symptoms are cognitions and behaviors. And if you'll keep those two apart, you can then understand that when symptoms reach a level that they start to produce serious consequences to the individual, serious impairment to the individual, that is when a disorder begins. Disorders begin where impairments begin. To put it another way, just because you have a number of symptoms of ADHD or SCT doesn't mean you have a disorder. You could just have a sparkling personality, a vivacious, talkative, gregarious, engaging, impulsive individual, none of which makes you psychiatrically ill. But to the extent that you start to experience harm relative to other people, you have a disorder. And by the way, harm can be classified as three types. There is morbidity, which is injuries to you. You're more likely to be injured by your disorder. Physical morbidity. There is mortality. You're more likely to die if you have this disorder. Think of bipolar disorder and the high risk for suicide by adolescence and young adulthood. And the third is harm in a major life activity. You cannot function effectively like other people are able to do. And here we would look at school, work, peers, family functioning. And in the case of adults, of course, we would be looking at child rearing, driving, managing money, your ability to cohabit with other people if you choose to do so, marriage, for instance, and so on, besides your occupational functioning. So there are three kinds. There's morbidity, mortality, and then there is impairment in major life activities, harmful effects. And you only have to have one of those to qualify as a disorder. Now, I didn't go through it this morning, but ADHD meets all of them. You may not be aware of it, but certainly people with ADHD not only experience impairments in work and school and so on, they're 3 times more likely to be dead by 45 years of age. They probably have 7 to 10 years shorter life expectancy than other people. And certainly, they have a high rate of accidental injuries starting out in childhood and progressing well into adulthood. ADHD is a major risk factor, for instance, for coronary heart disease, not to mention obesity, bulimia, and many other medical complications. So ADHD is a very serious condition. Many people aren't aware of the morbidity and mortality risks associated with it, but they are there, even if they're relatively small compared to things like cancer and heart disease and so on. They're there. ADHD is a public health risk because of its linkage to all of these other healthcare problems, not the least of which is suicide. So disorders begin where impairments begin, and we're going to want to be asking, what are the impairments associated with SCT as well? Now, to acquaint you to SCT, here is a list of the 14 most common symptoms explored in research studies of this population. And you can see many of the things that I've already mentioned to you on this list. I would like to point out, however, that papers in the past year, my own included, have found that items 13 and 14 are as likely to to link up with ADHD as with SCT, which means they're not useful for diagnosis. You'll hear them, but you couldn't differentiate an ADHD from an SCT client if you focused on those two. So it's really the top 12 that are the most informative about this disorder. Now, the research also indicates that those 12 symptoms, and some people have studied as many as 25 to 30, but those are the big 12, I would say. And what we find when we study them statistically is that they form two highly related dimensions, just like ADHD does. ADHD has an inattention dimension and a hyperactive impulsive dimension. And although we distinguish them, we know that they're highly correlated with each other. If you're high on one, you're likely to be high on the other. In fact, the correlations are as high as 0.8, which means that they're almost measuring the same thing. But it's helpful to distinguish them clinically anyway, even though we know they go together. And SCT also does that. There's a cognitive dimension, which is the daydreaming dimension, the sort of mental confusion. And there's a motor dimension, which is the sluggishness, the hypoactivity, the slow motor movement that we see in these patients. So we can say, first of all, that the answer is yes. The symptoms are unique and they cohere. And they're not related to ADHD. They're related more to each other than they are to the ADHD symptoms. So if I were to get a questionnaire of all of these symptoms, ADHD, SCT, anxiety, depression, would I see SCT forming its own dimension? And the answer is yes. So as far as the first criterion is concerned, we can look at SCT as a coherent pattern of symptoms that is distinct from other attention disorders and other forms of psychopathology. That's very important. And by the way, we find out whether we use rating scales, whether we use parent reports, teacher reports, other reports, whether we do direct observations of patients in their natural setting, like children in the classroom. We find that this pattern of behavior breaks away from ADHD. Very important. We also have some evidence, very small body of literature, not consistent, but suggestive that this is a processing disorder, that the information that the individual is being asked to attend to, they don't process very quickly or accurately. They make more errors in the processing of information. There was one study, only one, that suggested that there's something about the posterior cortex that is not reacting to stimulation as quickly. This is where we process information back here. That's what I said this morning. This is the knowledge brain back here. And it looks like SCT is more of a posterior hemisphere disorder than an anterior frontal lobe disorder, but all just very suggestive. Nonetheless, there is this pattern of very poor processing and making lots more mistakes than other people make in information processing tasks. Now, before you run off and say, oh my God, this is central auditory processing disorder under another name, right? This is cross-modal. It doesn't matter what modality we're looking at, whether it's hearing, whether it's vision, doesn't matter. They're having difficulty with focusing and processing information. So it's not CAPD. It's not inattention in the auditory domain. By the way, you need to understand that CAPD is a fashion trend more than it is a disorder. The literature that supports the diagnosis of CAPD is weak to non-existent. In fact, people are now trying to build that body of evidence, but which is unfortunate because it's become a clinical phenomenon, even if it doesn't have any scientific credibility to it. But to return to this is not CAPD because it's not just auditory. It's also seen in the other sensory modalities. Now, one of the things that's very interesting about these people is they're just generally slow. So when you do something as simple as a reaction time task, you find that their reaction times are much slower than those of other people. Whereas with ADHD individuals, in contrast, what you get is a high rate of variability. From one trial to the next, from one moment to the next, the ADHD person is all over the freaking map. Indeed, so badly are they variable that Marcel Kinsborn in 1977 referred to ADHD as VD, variability disease. It is a hallmark of the disorder, right? If you were looking for any single score on a test to tell you if somebody was ADHD or not, the single best score out of everything we've looked at is reaction time variability. Now, because your reaction time is variable, your mean reaction time will be slower too. But it's the variability that's driving that. Whereas these kids and adults are not variable. They're just slow. So there's quite a difference when we look at the patterns on these cognitive tests, even though it's only just a few studies that have examined the cognition of these individuals. Now, some of the studies, very few have even looked, gave the sort of Mirsky, Posner attention batteries to these people. And as you know, as I've said, there are 6 kinds of inattention. There's sustained attention, which is persistence, which is ADHD. There's selective attention. How quickly can you pull what's important out of what you're processing? These people have more trouble in that domain. Their problem isn't with persistence, it's with focus, the ability to select out. And I know you heard Pat Quinn mention hyperfocusing as an attribute of ADHD, but that's not true. Hyperfocusing is what we see in autism, where you focus too much on details. What you see in ADHD is perseveration. And that's a better term for it. Perseveration is a symptom of a frontal lobe injury. It means that you continue to persist at tasks that you should have shifted away from to get something else done. But you stayed the course. There you are, playing Warcraft as the bus is coming down the street to pick you up. Now, you can call that hyper-focusing on Warcraft, but the fact is you're perseverating in a highly reinforcing activity when you should have shifted away from that activity. The inability to shift across activities, which is perseverative, is a symptom of ADHD and of a frontal lobe disorder. So I don't like the term hyperfocusing. I know Ned Hallowell uses it. I've heard Pat use it before. But technically, it's not correct scientifically to be using that term. Whereas SCT is a focusing disorder. But instead of over-focusing, they don't focus enough. They can't quickly get to what's important in the information they're processing. And as a result of that, they make more errors than other people do. But again, the question mark is here to emphasize a very thin literature so far. But what exists is pointing to some unusual differences in the kind of inattention we see here. Now, one of the things that is completely uniform across all studies that have looked at it, so this is a fact in the bag, SCT is not a disorder of inhibition. ADHD is a raging disorder of inhibition. So diagnostically, if you wanted to differentiate the two disorders, you wouldn't so much focus on inattention as on inhibition, because that would be the discerning attribute. People with SCT have no problems with impulse control. If anything, they're slower to react to the environment than typical people are. And if you look at the kind of inattention, people with ADHD can't persist over time to the future, to the goal. And they are distractible, which means they can't resist reacting to goal-irrelevant events. That's a description of the attention problem in ADHD, and that is not characteristic of SCT at all. These people do not have problems with persistence and distractibility. What they have problems with is daydreaming. That's the staring, the mental confusion, and so on. So clinically, you want to be listening for these differences. But if you just listen for inattention, you would leap to the conclusion everybody's ADHD. Well, there are many different kinds of inattention, only some of which apply to ADHD. By the way, every psychiatric disorder produces inattention. So if a patient says to you, I'm inattentive, you don't know what is producing that. They could be psychotic, they could be manic, they could be panic attacks, OCD, Tourette's. All of them in their various ways will interfere with attention. What we listen for in ADHD is the inability to persist toward a goal. Future-directed action. And then coupled with that is the distractibility that accompanies that. So this is a problem with focus of attention, errors in processing, sluggish responding, the slow motor movement, and not impulsive. So if you start hearing inhibitory problems, you better be looking at ADHD or mania, but not at SCT. Now, there is a little bit of evidence from cognitive test batteries that these people might have a very small problem with working memory, mainly in the verbal domain, on things like digit span backward or so on. It's not clear, however, whether those are primary problems. ADHD produces a massive primary problem in working memory, or whether it's secondary to the other cognitive problem they have, the sort of staring and daydreaming. In other words, there's nothing wrong with working memory, but you have to put something in working memory, and they may not be doing that as well as other people. So we're finding a little bit of executive deficits, mainly on test batteries, but not very convincing, and certainly very, very small deficits. We do find that school is a major problem for these individuals. They are as impaired academically as our ADHD individuals, which is hard for people to believe because ADHD is so impairing, but SCT is equally as disruptive to education. And parents have this as their singular concern. So when this child comes in for referral, the parents aren't concerned about, oh my God, he's up all night, he's tearing around the neighborhood, he won't sit still, he's taking risks, he's hitting other kids, I can't get him to listen to story time. We don't hear the distractibility in the teens or the young adults. Instead, what we hear from these people is he's failing. Does he have a learning disability? Why is he struggling so much in school? He's a nice kid. He's very compliant, he's in the band, he's got a few friends, he's a little quiet. But God, getting homework out of this kid is torture. But he's nice, right? A nice kid who does nothing. And you know what we do with those people? We socially promote them. And as a result, children with SCT are later to be referred than ADHD children. They will go on failing longer than ADHD children will because they're nice, right? They're not disruptive. So you may see SCT kids coming to you through a different referral route. They tend to come in through LD programs, educational programs, tutoring programs, and through developmental pediatrics. You're a lot less likely to see them coming into a psychiatry department because that's where people who are a pain in the ass go. But if you're just failing at school, people aren't as likely to call the psychiatrist on you, right? So if you're looking for these people, you may find them elsewhere, like LD programs, including LD universities. So school failure is a big problem for these individuals. Now, when we look at their schoolwork, and I want to emphasize again, there's not a great deal of evidence that's been accumulated here, but it's painting a rather interesting pattern so far. ADHD is a problem with production, amount of work done in unit time. Accuracy is far less a problem for people with ADHD. When they do their work, it's about 85% correct, which is only 9% below normal. For normal kids, it's about 94% correct. So it's not a major difference here, which is why when you give medication to ADHD individuals, their accuracy doesn't go up very much because it wasn't the problem. What goes up markedly is production. They're finally doing something, right? So the problem with ADHD in school is productivity. They don't do any damn work. But if you can pull the work out of them, it's not bad. But it's getting them to sit and produce. So ADHD is a production disorder. SCT is not. It's an accuracy disorder. It's the inverse. And I'm oversimplifying here a little bit to make a point. But here the major problem is mistakes. You get all your work done, and half of it's wrong. You missed the little cues. You didn't see the dot above the line and below the line when subtraction became division. And you just kept doing subtraction. So the second half of your paper is wrong. You fail, right? That's the kind of mistakes we're looking for, these failures in detection, rather than you just didn't do your work. But both will produce impairments. Now, fascinating, we have 3 papers so far that show that both groups are equally as likely to have learning disorders, which means that between 35 and 50% of people with these disorders have a primary learning disability that links up with it. But the pattern of the learning disabilities is looking different. This links to math disorders. ADHD has much more of a linkage to handwriting, language, reading comprehension, and reading speed. And although there's a little problem with mental arithmetic, it's only when it's mental, so it's not math. It's the working memory part of mental arithmetic. You can't hold the problem in mind to do it. But that's true of everything, not just arithmetic. You can't hold information in mind from the stories that you read, from the movies that you watch, from the narratives that the teacher reads to you. People with ADHD, because of this massive working memory problem, do not get out of material what other people do. They have a pervasive comprehension disorder, whereas SCT children don't. So we're seeing then that there are some differences here, possibly in the pattern of learning disorders. And this might track more with mathematics. Doesn't mean they can't have the reading, the spelling, and so on. They may, but not as much as the math disorders seem to be. Time will tell if that holds out to be true. Now, one of the most striking observations that has been found in every single damn study, so just like inhibition, we're going to put this as another fact in our bag, is social shyness. SCT children are withdrawn. They're more passive socially. They're a little apprehensive. Some of them are characterized as socially anxious. Shyness might be a better term. But withdrawn is the larger pattern. They're just less engaged with other people socially. Now, I want to be clear. We are not talking about high-functioning autism, schizotypal personality. That's aloofness. They don't value interaction with other people. That's not shyness, right? There's a problem in the social module of the brain that links to autistic spectrum disorders. These people are fine. There's no oddities or peculiarities. They're quiet. If you read the book 2 years ago, the bestseller, Quiet, this is what we're talking about. They're just less engaging. They don't talk as much as other people. They don't interact as much as other people. What we find is that they have more friends than ADHD children do, but not as many as normal children do. And the same is true with the adults. They have friends, just not as many. Whereas ADHD individuals, by the time they're in second grade, 50 to 70% are utterly rejected and have no close friends. And that pattern continues even into adulthood, where their friendships have very short durations. There's a lot of turnover in the relationships of people with ADHD. And we don't see that here. We just don't see them having quite as many friends. They're not the social butterflies. So we have a problem with social withdrawal that is very characteristic and even disabling of some of these individuals. Another thing we see is in comorbidity for other disorders. Yes, ma'am? We looked at that. Very good question, because this would make you think of a nonverbal learning disability. And here's what we find. People with SCT don't have nonverbal learning disability. People with nonverbal learning disabilities have this as their primary attention disorder. It's a one-way street. So they're not the same disorders. But are they linked together in a one-way direction? Just as Tourette syndrome predisposes to ADHD, but not vice versa. Just as bipolar disorder predisposes to ADHD big time, but ADHD does not predispose to bipolar. So do you see what I mean by a one-way comorbidity? But yeah, this is the attention pattern that, nonverbal learning disabled kids would have. But this is not a nonverbal learning disability. So we looked at that in the very first study we did in our clinics of these individuals. Another fact in the bag, very well established, is the risk for other disorders. Now, 80% of people with a psychiatric disorder have a second disorder, and 50% have a third disorder. This is especially true in ADHD, so that comorbidity is very common in ADHD. And we see that here as well. But the pattern for other disorders is different. For instance, ADHD, the number one comorbidity is oppositional disorder, followed by conduct disorder, followed by learning disability. We don't see that at all in these people. There is no risk for oppositional or conduct disorder linked to this disorder. In fact, if you control for any overlap SCT might be having with some ADHD symptoms, it's become negative, meaning the more of this disorder you have, the less likely you are to be oppositional compared to even normal people. So we're beginning to see here some contradictory patterns, contrasting patterns, what we call in science a double dissociation, where this disorder links to that deficit, the other disorder goes in the opposite direction. That's very important in arguing that these are two separate disorders. And the pattern of comorbidity suggests that. By the way, if you don't have any risk for ODD or CD, you don't have any risk for substance abuse, antisocial personality, or crime. because those disorders are the precursors to antisocial behavior, psychopathy, criminal behavior, and drug abuse. And since you don't have those, we would predict that your life course is going to be quite different from people with impulse control disorders. We do, however, see an opposite pattern. There's a high risk for depression linked to this disorder. But it's not depression. One of the things we looked at is, are we simply giving depression another name here? And it turns out that the majority of people with SCT don't qualify for depression, but they're more likely to than ADHD or typical people, which means that there's something about this disorder that predisposes to depression, but it isn't just depression. So again, a very important difference here. So there is a stronger link to what is called the internalizing dimension of psychopathology, anxiety and depression, but especially depression, whereas ADHD is a stronger link to the externalizing disorders, the conduct problems, the antisocial behavior, the drug use, the risk-taking, ODD, so on. So that's a very interesting pattern. Now, recently, 2 papers were published this month in that journal that looked at personality traits linking up to these 2 disorders. ADHD links up with risk-taking and low levels of conscientiousness, concern for the future. You're disinhibited, immediate, live in the now, damn the torpedoes kind of person. We would refer to you as being low conscientious and having a high time preference, meaning you want it now. Right? Waiting is very hard for you. With this, we don't see that at all. So you see here that ADHD is linked to sensitivity to rewards, risk-taking, and low conscientiousness, which I didn't put up here, whereas SCT is linked to an oversensitivity to punishment, so that they're concerned about getting it wrong, and also with a withdrawal factor, as you might expect given their social profile. Now, when we look at the parents of these children, or at their spouses and partners, we find that the concerns that these people have about them are very narrow. Whereas when you study ADHD children and adults, the concerns are pervasive. In virtually every domain we look, you're in trouble. Whereas with SCT, there's a lot of your life that's good, that's okay. But school and work are where the problems tend to gravitate. And then second to those would be the social shyness. Only 2 studies have looked at family history of mental illness. My study found that there was a greater history of anxiety disorders and learning disabilities in these families. But a second study did not find that. So I don't know whether it would make sense, given what we already know about these people, that they would have family members just as likely to have these patterns, but we don't know. All right, so let me very quickly share with you the 2 largest studies ever done, and they're mine. And I did them in the last 2 years. These are surveys of the entire US population using random samples. Random samples means we sampled every ethnic group, gender, age. These studies go from age 5 to 92. We hired national survey companies to pull representative individuals from everywhere in the US. So they're not very large samples, between 1,200 and 2,000, but they're representative of the US. Very important. What did we find? This is the study of children, 6 to 17 years of age. We found everything I just told you. Everything that had been found in earlier studies occurred in this study in spades. But there were a couple of very interesting findings that other studies hadn't even looked for. There's no sex difference in this disorder. In ADHD, it's 3 times more common in boys than girls. Now, I want to remind you, however, what you may not know is that by adulthood, there's almost no sex difference in adult ADHD. The ratio is only about 1.4 to 1, males to females. Something is happening over development where females catch up with males. So that by adulthood, there are no qualitative differences between men and women with the disorder. In their disorder, there are differences in comorbidity, differences in impairment, but that's because women are different than men. But the disorder itself is not qualitatively different between the 2 sexes. Nevertheless, in children, ADHD is 3 times more common in boys than girls. We did not find that here at all. The other thing we found is there was no effect of age. ADHD declines steeply with age, especially its hyperactive component. In fact, the hyperactivity declines so markedly that by late adolescence or adulthood, it is of no diagnostic value. Never ask your students about hyperactivity, because it will not help you at all. In fact, after age 30, it starts to track with anxiety disorders, restlessness. What you will hear them say is that they feel internally restless. I need to be busy. I'm thinking about lots of ideas, and I don't finish anything that I do. But adults with ADHD don't climb on furniture and that sort of nonsense. So the hyperactivity is going away very quickly, whereas the executive deficits are not declining so quickly. Nonetheless, there is a decline across ages in ADHD up into your 30s. Now, some of that decline isn't just developmental recovery. Some of it is altered life expectancy. The older the sample, the less likely adults with ADHD have survived to that age. So that by the time you get into your 50s and 60s, the prevalence of ADHD in the elderly population is 3%. You've lost 2% of the population. And that's not growing out of it. That's being culled from the population, because people with ADHD are less likely to be around, more likely to have a shorter life expectancy. Whereas SCT, we don't see that. SCT is flat from age 5 to 92. So when it's there, and it stays there. We found that quite opposite of what we expected. SCT in children was linked to a number of areas of social disadvantage, particularly parental unemployment and parents being divorced or out on disability from work. I would have expected that to link more with ADHD. It did, but this was even worse. Now, that's kind of interesting because it begins to suggest there might be some environmental factors that are linking up with SCT, maybe causing it or at least making it worse. I don't know. But you don't see that as much in ADHD kids. SCT children are older at the time of referral by about 2 to 3 years. ADHD children tend to get referred usually between about 5 and 8 years of age. SCT kids, it's right around 8 to 12. Now, part of that is that social promotion we talked about. They're going through school and failing before people finally get off their butt and do something about the failure. But there may also be a later age of onset to the symptoms as well. We don't know. We did find that the prevalence matches ADHD perfectly. About 4 to 5% of children have SCT, and the same is for ADHD. Now, I know you've heard figures that ADHD is closer to 7 to 8%, but that's because SCT kids were put in it. Remember the inattentive ADHD group? Well, the minute we invented inattentive ADHD, we doubled the prevalence of ADHD, because we started letting people with attention problems in who didn't belong there. Once you start pulling them out, the prevalence of ADHD drops back to 4 to 5%. So part of what we were seeing in prevalence studies is these kids being called ADHD, when if you pull them out and you identify them directly, are equally as prevalent. Now, this was kind of startling. We gave my executive function rating scale to the families of these children, and we found that ADHD was the worst. That's the red bar. Okay. And if you had both disorders, by the way, according to this view, you can have both disorders. According to the DSM view, you can only have one or the other because they're subtypes. But if you view SCT as a distinct disorder, there's no reason it cannot coexist with any other disorder, like learning disabilities, depression, and ADHD. So, people with both disorders were markedly worse than people with SCT only. And of course, ADHD was worse than SCT here. Now, this makes it look like the SCT kids in the yellow bar had executive deficits, but they don't. Because the minute you do statistics where you covary out any relationship between the two disorders, there is no executive deficit linked to SCT. None. It falls to 0. Whereas if you leave it in there and you allow for the overlap, it looks like SCT has executive deficits. To put it another way, SCT is not a disorder of executive functioning. And to any extent that you see those deficits, it's because there's a little bit of ADHD there too. Control for that, it goes away. Yes? Oh, yeah. Yes. Yes. No, we didn't do that, but the deficit on intelligence testing that they were likely to have is slow processing speed. That was it. And that's what's pulling down the overall score. If you remove that, their IQs are normal. So this disorder, by the way, if I can use your question as a springboard to answer it before I forget it, SCT has no link to intelligence. ADHD does. If you have ADHD, you're going to lose 7 to 10 points off your IQ score. The correlation between ADHD and IQ is negative 0.3 to 0.35 roughly, which means that about 9 to 10% of the variation in intelligence is being stripped out by your other disorder. Well, think of it. I mean, your IQ score, part of IQ testing is executive functioning. And ADHD is an executive disorder. So it ought to pull your IQ score down. Whereas SCT shows no such pattern. Once you get slow processing speed out of there, you know, the sort of digit symbol coding kind of test, okay. So this has no detrimental effect on your intelligence. That's not the case for ADHD. Nobody's looked. I would guess that they might, but we don't know. Here again, sensory integration is more fad than science. It's as bad, if not worse, than central auditory processing disorder in terms of the trivial body of scientific evidence behind it. And certainly, SI training has been shown to be a failure for these disorders. That we already know. We don't even go there. So, but you could come back and say there might be something sensory about this disorder. And I would agree with that, but I wouldn't go so far as to put it into the Jane Eyre's sensory integration camp. But there might be something there, okay. Certainly, I don't know about things like tactile defensiveness. I'm referring here more to hearing, vision, that sort of thing, rather than to the tactile senses. No, not yet, okay. So we don't know. But I'm going to show you a few things that have been looked at, and you would be right on the money, okay, to want to even look at that. There might be something there. Okay, to continue then, it looks like it's ADHD that is driving the executive deficits. Look at this. ADHD accounts for up to 3/4 of the variation in rating scales of executive functioning. This is what I said this morning. ADHD is EFDD, right? You're just naming the disorders differently, but they're the same damn domain. When I put ADHD symptoms into an analysis and I put in executive rating scales, they're the same dimension. You don't get two separate disorders. It's all there as a single construct. You put SCT in, it doesn't link up with executive deficits at all. Look at this. 1% of the variance in the rating scale was due to SCT. That's trivial. So SCT is not an executive disorder. ADHD is. And by the way, this has been replicated. If you're familiar with the brief rating scales for kids and adults, it's not just my rating scales that we see these patterns. Here is something fascinating. We looked at 15 domains of impairment in our children using my children's impairment rating scale here. And by the way, this is the most comprehensive rating scale of impairment. I was shocked to see that we don't have very good scales measuring impairment in people. None for adults, by the way. None. You realize that in the history of psychiatry, there's not a single normed rating scale for assessing impairment. That's because everybody goes around doing the DSM-4 global assessment of functioning 0 to 100 guesstimate, which is one of the most unreliable things that you could do. So when we went out and did our study, we actually created an impairment rating scale for adults because we were collecting norms, and so we have it. That's not to sell rating scales, it's simply to point out a fact. Now, here is the rating scale for children. We assess 15 domains of functioning here, and you can see the groups again, the 4 groups that we split the kids into. Once again, I call your attention to the more obvious pattern. If you get both of these disorders, you are markedly impaired. Now, why is that important? Because they're additive. And if they're the same disorder, they wouldn't be. People with both disorders should be no worse than people with ADHD because, after all, it's ADHD. But when people with both disorders are worse than people with one or the other, it's an additivity effect. And that tells us there's something unique about SCT that is not just ADHD under another name. There's something different about this disorder. And if you have both disorders, you're in trouble. Now, I do want to point out, you see these asterisks? This is where ADHD kids were markedly worse than SCT kids. But sports went the other way. SCT children were much worse in sports performance than ADHD kids. Very interesting. By the way, ADHD children, if they have trouble with sports, it's distractibility. Here, it's probably just the daydreaming, you know. You don't want somebody with SCT being your goalie. Yeah. So. We also found, by the way, that they were a little more impaired with their fathers, but once we took out the sports relationship, that went away. So it wasn't anything specific about dads, other than that fathers are a little more likely to engage in sports activities with their children. It was simply a sex difference in sports engagement. So here's what we found. ADHD was twice as impairing as SCT in terms of the number of domains in which you were impaired, and the severity of the impairments was marked. But also we found that SCT was more impairing in your social leisure life. ADHD was much more impairing in work than SCT. So some very interesting differences here. Now we get to the interesting question. Can these two disorders coexist? And the answer is yes, by about half. How many people with SCT had some kind of ADHD? Well, there they are. But I would caution you that this is probably inflated, because SCT would push up the inattention items on any ADHD rating scale. And it doesn't necessarily mean you're ADHD. After all, these are the people calling ADD or inattentive ADHD. Nonetheless, there was some overlap there. Notice, by the way, that only 40% of ADHD people qualified for a diagnosis of SCT. But let's put it this way. While they do overlap considerably, right, at least half or more of the people with one disorder didn't have the other one, which means they're independent as well. I want you to think of the relationship between anxiety and depression. They're distinct. You can have one disorder or the other. But the older you are with one, the more likely you have the other with it. We think of that as comorbidity, not equivalence. We don't think of anxiety as depression or vice versa. And this is the same thing you're seeing here. Two disorders that can link up with each other, but can be independent of each other in most cases as well. And then this is what we found. We looked at 22 different diagnoses in the children to see which disorders you were more likely to have. Well, ADHD kids were much more likely to have ODD and conduct disorder, and you can see that here. But SCT children were not likely to have ODD, but they were more likely to have a diagnosis of depression. So that's what we found earlier in the other studies. This study finds it yet again. There's something about this disorder and depression. Both were equally likely to have learning disabilities, as I pointed out to you. We didn't look specifically at math disorders here. 50% of the ADHD cases had a prior diagnosis of ADHD. Only 14% of the SCT children had been diagnosed at all. This is what I mean. This is kind of a silent disorder that kind of goes around out there, but people don't pick up on it quite as quickly as other kids with ADHD, for instance. And you can see here that about half of the SCT children had no other disorder. That's very unusual. ADHD, on the other hand, are highly likely to have other disorders. Okay. So that's the kid study. Now that essentially replicates all the other childhood studies. But that's the end of it. That's all that's been studied was children. And so in this study, we also went on and took a random sample of adults and did the first study of SCT. It was the only study until last week. Last week, 2 studies of college students were published with SCT. And by the way, those studies replicated everything here, so they don't really contain anything new, other than to say that SCT is in the college population, and it is a very impairing disorder. So here's what we found with adults. Exactly what we saw with the kids. No sex differences, no change with age, later age of onset, 5% prevalence, roughly about the same as it was with the children, and the symptoms were quite distinct. And yet there was overlap. Once again, half of the cases with one had the other, and half of them did not. So we also found that SCT was linked to daytime sleepiness. And a study among college students has found that that is the case as well. The reason we looked at that is because SCT sounds like a hypersomnia, doesn't it? In psychiatry, you would call it hypersomnia. You have trouble with sleepiness throughout the waking day. And so a study of college students found that, yeah, there is a correlation between the two, but they're distinct. They're not identical. So again, SCT is not another name for sleepiness, right? Daytime sleepiness has its own symptom dimension, but they can link up with each other, as you see here, a correlation of about 0.5, which means they share about 25% of their variance. Again, we found SCT was very impairing in educational settings and more impairing in work than ADHD. That was a shocker. Adults with SCT reported that they were markedly more impaired than the adults with ADHD did. Now, here again, this is the executive function rating scale, and it looks as if SCT people might have some executive deficits until you remove the overlap with ADHD, and then it disappears. So once more, ADHD is the executive disorder. SCT is not. Now, this is the impairment rating scale that we gave to these adults. And here you see what we found with children, additivity. If you have both disorders, you're in big trouble. If you have ADHD, you're the second most impaired group. SCT was the third most impaired, except you see the asterisks? Those are the domains in which SCT was worse than ADHD in adults. Work, education, and sex. Sexual relations and sexual activity with others was indicated to be quite impaired, actually, by this disorder. That was a bit of a surprise. I was all sort of scratching our heads. What is this disorder doing? So one night over dinner, I was telling my wife about these results, and she laughed and she goes, "If we are being intimate and you space out, you are dead. That's toast. Game over." I mean, you can imagine trying to be intimate with somebody who's I mean, it's almost the inverse of intimacy. So consequently, I think that may be the reason. Well, I don't know. It's just a very, very strange finding. By the way, ADHD was quite impairing, and it was more impairing of child rearing, driving, and other domains, not just education and work. All right, so what the heck is going wrong? What might be the cause of SCT? I'm going to start out by saying we're not sure. But we now have several studies, the first of which is the first study of heritability published last week. A giant twin study done in Europe assessed SCT along with ADHD. So here's what the studies are indicating. We don't have any neuroimaging studies yet, but I know 3 are underway. 2 in California, 1 in Brazil. So we're going to have the answer to that here very shortly. But what we can say is if we look at the SCT symptoms, they're more linked to children with leukemia or other brain injuries. This is the attention disorder that is linked to fetal alcohol syndrome. Everybody thought it was ADHD. It isn't. It's this is more linked to fetal alcohol syndrome. Explaining, by the way, why if you give stimulants to these 2 groups of inattentive children, they don't work very well. Stimulants are not very effective at dealing with the inattention in children who have leukemia and survive it, or children who may have had fetal alcohol syndrome or other brain injuries. So it's kind of interesting to see that, at least to a scientist like myself. Now, here's the result of the twin study. SCT is markedly heritable. 50 to 60% of the variation in the trait is due to genetics. That is very important, but it's not as heritable as ADHD, which is 70 to 80% of the trait is genetic. So both are striking. SCT, by the way, is more genetically influenced than anxiety and depression, which is only about 0.4 in its heritability. But it's not as much as ADHD. They also found that some of the genes for one disorder were also genes for the other disorder, accounting for the overlap. But very interesting, they found that also a percentage of the variance was unique, meaning each disorder had unique genetic effects that didn't overlap with the genetics of the other disorder. So even though the study doesn't look at genes specifically, it's telling you that there will be separate genes for SCT than there is for ADHD, but they will share some of their genes as well. This is precisely what we see in autism and in dyslexia. ADHD shares genes with autism. It also shares genes with dyslexia, particularly reading speed. But most of the genetics are distinct. and yet a few of the genes are common, and that is why you can see both disorders together. It's why 20% of ADHD children qualify for an autistic spectrum disorder, and 40 to 50% of autistic spectrum children have ADHD as a comorbidity. And now we know why. There's genetic liability to both disorders that underlies them. So that was fascinating. So again, genetics is contributing to SCT, but not quite as much. And the study found that the environment, unique environmental effects, were larger in SCT. Now, unique environment simply means this: something that happened to you and not to anybody else in your family. Shared environment are things that happen to you and other people in your family. How you were raised, the diet that you had at home, how much TV, where you grew up, the schools you went to, the size of the house, the resources of your family. These are shared across siblings. Unique environment refers to things you don't share with your siblings. You fell down a flight of stairs. You got H-flu meningitis. Mom smoked like a chimney during your pregnancy, but not during the others. Those are unique effects. And notice, by the way, they can be biological effects. Environment here doesn't mean social. It can also mean biological, toxic effects. All of this is to say that there may be environmental contributions to SCT more than even to ADHD, but they probably fall in the realm of biology. Okay, SCT was also linked to a greater family history of adversity, as I pointed out earlier. Right? So is PTSD. So might some SCT symptoms be driven to some extent by social stress, turmoil, so on? Maybe. Could possibly be. We don't know. The most fascinating explanation for the nature of SCT, however, is the last line. We've been toying around with, is SCT a disorder of the brainstem? You're just not aroused as much? Doesn't look that way. Is SCT possibly a hypersomnia? We already have the answer to that last week. Overlaps with it, not perfectly explained by it. So, is SCT a problem with the focus element of attention? Probably, but that doesn't completely explain everything that we're seeing here. This one is absolutely fascinating. Pathological mind wandering. So allow me to explain to you what mind wandering is, because it has a very extensive literature in psychology. Mind wandering is where you are doing a task that doesn't command a lot of executive functioning, driving to work. It's a goal-directed task, but it's overlearned in its primary, and most of it's being done by your automatic brain. Right? So what do? You've got all this excess executive capacity that you've been blessed with. You start to multitask, don't you? So you start to think about your schedule, your day, your appointments, what happened at home, the argument with your wife or your teenager, and you need to get the car inspected. You got all these kinds of things going through your mind while you're driving. We all do that. It is a very efficient use of your executive system to allocate it to a second problem when you're doing a primary task, until you forget to turn into the parking lot. And then the secondary task interfered with the primary task. Now, we all do that occasionally. What if you do that every day on every task? The secondary task interferes with the primary task consistently. That's pathological mind wandering. There's a beautiful description of cases of pathological mind wandering, by the way, in Scientific American Mind. Scientific American publishes a separate magazine on psychology called Mind. And 2 years ago, in the 2011, I think it was, edition, you will read beautiful cases of pathological mind wandering in their description. So if you're interested, that is a very good place to go have a look about what do these cases look like. In any case, pathological mind wandering is where there's nothing wrong with your executive system other than that you keep allocating it to other issues. And it's always interfering with what you're supposed to be doing. Right? Which is just another way for daydreaming. Every time you're asked to do something, your mind wanders to something else. Now, what's interesting about mind wandering that you might not know is when we all engage in mind wandering, it tends to be negatively biased. Are we as likely to think of the good things or the bad things? If you're driving to work, are you more likely to think about unresolved issues, problems, conflicts, things yet to be dealt with? The answer is yes. More than successes, achievements, things that you were able to accomplish quite effectively. Your executive system is a problem-solving system, so it tends to drift more to what are your existing problems, which means it has a negative bias, which means pathological mind wandering is correlated with depression. The more mind wandering you do, the greater the risk of depression, dysthymia, demoralization. And what do we see in SCT? A higher risk for depression. So even though we cannot today definitively say that SCT is pathological mind wandering, it's a very enticing conceptualization for this condition, but we don't know yet. There are tasks that you can do in a lab to study that, and nobody's done it. So that's a dissertation. Let's talk about the implications of SCT for treatment, and then we can take some more questions if you like. What would we expect to see in SCT? Well, we only have a handful of studies of treatment. They're all done with children. None have been done yet with adults. But given what we know today about the disorder, we can infer some issues around treatment. First of all, studies that have used stimulants with people who are only inattentive, who are highly likely to have SCT, find that they don't work very well. They're very disappointing. They don't hurt you, but they don't help you. So if you give methylphenidate or Concerta or one of the delivery systems to somebody with SCT, you're probably not going to get a very good response. You're not going to hurt them. Go ahead and try it. What we found in our study of children is 1 in 5 responded. If they were going to respond at all, it was at the starting dose, the mild dose. Whereas ADHD, you got to push the dose up. And we found that the more we push the dose up, the less likely they were to respond. An inverse dose effect. But only 1 in 5 of the kids was kept on their medication after the trial. 92% of people with ADHD respond to one of the medications on the market today. That's a marked difference in drug response. And while I can't guarantee that that will replicate in the adults, the pattern suggests that SCT is not really the disorder for stimulants, like methylphenidate, dexedrine, those sorts of things. So we don't know. Now, a month ago, the one and only drug study of people with SCT, specifically chosen for having SCT, was published. It used Strattera, atomoxetine. And it found that Strattera was as good for SCT as it was for ADHD. Even removing any overlap it had with ADHD, they still got clinically significant improvement in SCT. So that needs to be replicated with adults. Other people need to replicate it as well, because we don't like to go on just one study. But it's a fascinating study suggesting that maybe norepinephrine drugs might be a little better for this group, but we don't know. By the way, since SCT does link up with internalizing disorders and norepinephrine drugs are used to treat anxiety and depression, it wouldn't be out of the realm of possibility that you would see a norepinephrine drug being useful here. But it's, at this point, largely hypothetical. So don't know whether the stimulants are very good or not. Initial results are not looking very promising, but we need to do more. Norepinephrine drugs like atomoxetine seem to work in one study, but we need more research. Those are the only drug results we have so far. There's only one study of behavior modification with SCT. That was done by Linda Pfeiffer, and she found that these kids responded very well to homeschool contingency programs. Very similar tactics that we use for ADHD, except you're targeting their daydreaming, spaciness, sluggishness, rather than disruptive, aggressive, talkative behavior. But the techniques were the same, and the kids did pretty well. It's possible that these kids do very well in social skills training. There are 2 reasons to think that. First of all, there is a study by Kevin Anschel that shows that they are somewhat better at responding to this. Second is social skills training was invented for shy people. And the most abundant literature supporting it is among shy people, not disruptive and aggressive people. So that would fit if if SCT tracks with anxiety and depression, then we might find that social skills training is better for them. By the way, social skills training is an abysmal failure for ADHD. Absolutely awful statistics. We don't recommend it any longer. And in fact, 1 in 5 children put in a social skills group gets worse because of a process called deviancy training. When you mix aggressive children with less aggressive children, they train up the other children to become more aggressive. It happens whenever you start your children in kindergarten, by the way. There is a spike in aggression among children, and that's because they're now interacting with other people who are more aggressive, and they pick it up. So there is a deviancy training that goes on whenever you group aggressive people together. It's been found in group homes for delinquents. It's been found in juvenile justice. Obviously, prison systems are a good example, as is special education. So watch the composition of these peer groups because you get deviancy training. Now, lest I get too negative about social skills training, there are 2 new procedures that were developed in the past 2 years for social skills training for ADHD children that are finding good success. They're developed by a woman named Omori Makami. Omori is at the University of British Columbia, and one of her programs is called Friendship Coaching. She teaches parents to be therapists. So you don't go to a group, you don't come to my clinic, I don't take you out of school for social skills training. I train your parents to do what a therapist would do every day, using the natural flow of interactions as the training template. Notice what she did. She took my theory of executive functioning and said, if it's a performance disorder and you've got to treat it at the point of performance, that's where the therapy has to be. Not in my office, not in special ed, out there with the kids he's got to interact with. And she is having very good success. When she finishes up her grant, she's now on her 3rd study. She's going to publish the manual commercially, so you will be able to buy the manual for friendship coaching. And then last year, she extended it to teachers. It's called Mosaic, and it's training for social inclusiveness in classrooms. And she's getting very good effects, better than any other data we've seen for social skills training. Founded on the same idea. ADHD is a performance disorder, so don't spend a lot of time on skill training, and do it at the point of performance, not in a pull-away environment, and then you get results. So it's very nice to see a theoretical proposition used to design a treatment that then boosts the effect of the treatment by following the theory of performance. No one has done cognitive behavioral therapy for children or adults with this disorder, but I think you should. CBT, first of all, does not work for ADHD. It has been found for years to be a failure in children and adolescents. So we don't do CBT for this disorder. But it did work for adults with ADHD, provided it targeted the executive deficits that the people had, and provided the adults are on medication during the executive training. Absent that, you're not going to get as much from them. So CBT may not work for children or adolescents that have ADHD, but it does work for adults when you target their executive deficits and put them on medication. That's a good finding. Right? But nobody has studied SCT. And I think it would be a great treatment for them. First of all, they don't have ADHD, they don't have the executive deficits, and they have internalizing disorders. And CBT is a very good intervention for anxiety and depression. Indeed, as good as medication. So wouldn't you want to revisit cognitive therapy for this group of adults and children? Maybe. This is a drug, medoxidine, all right, has been found very recently to be an interesting treatment for inattention, and some people are suggesting that it might work for this group of individuals. I don't know. There's only one study that looked at this, and they didn't really look at SCT, they only looked at inattention. So we don't know yet. What about modafinil, the anti-narcoleptic? That might work. I mean, after all, this is linked to hypersomnic states. Even if it isn't hypersomnia, that's a possibility. Some people have suggested that SCT could be a ruminative disorder, very much like OCD. You might not have the C, the compulsions, but you may have the O, the obsessions. So is this ruminative cognitively instead of mind wandering? Again, we don't know, but if that turns out to be true, the SSRIs might actually be interesting drugs to test with this population. We just don't know. Before I go to questions, I want to revisit the label. We started using this in our psychiatry clinics with families, and families love the information and hate the name. They find it offensive, derogatory, demeaning. Sounds like slow-witted, stupid, slow learner, mentally retarded, and all the old pejorative phrases. So we, in the past year, my residents and I were sort of casting around for what else could we call this without being misleading. One person has suggested, well, how about primary vigilance disorder? It's an interesting name. It's been used in the literature before, but it implies you know what's happened cognitively, and we don't. So I don't want to use a misleading one. Some people say, well, let's go back and use ADD for this group. That's all. That's what clinicians are calling these people. That's not a good idea because ADD was the name for ADHD in the 1980s up through 1987. So do you really want to create that kind of confusion among people? I don't think so. So the name we came up with, which I think works very well for the time being, is concentration deficit disorder, CDD. It gives no offense. It is not pejorative, doesn't suggest anything about stupidity or slow-wittedness. It keeps the focus in the area of attention, but it uses a different name from ADHD. After all, if you look up the definition of concentration, it means to focus your attention selectively on some things over others. See, ADHD doesn't involve the word concentration. It involves the term sustained attention, persistence. That's the problem. So, concentration deficit disorder also implies you could have both disorders. They're both attention disorders. They might well overlap, which they do in the population. So I think this solves a number of our problems. It doesn't imply a known cognitive impairment when we don't quite know what it is, and it's not offensive to people, and it's not been used before. So CDD might be a better term, and that's being picked up now among my colleagues in the past year, and also this is the name of the chapter on SCT in the next edition of my handbook, which will be out in August. I've just spent the entire past year completely revising my manual for diagnosis and treatment. 80% new material, tripled the number of expert contributors. The book is going to be twice as big because there has been 6,000 research papers on ADHD since 2006. Just since 2006. There's 1,000 articles a year hitting the journals right now on ADHD. But in that book, I have a whole chapter that summarizes everything you just heard today on CDD. And this is the name we're using in the textbook. We're trying to push people away from the SCT diagnosis because of its clinical offensiveness. So let me ask you, what do you think about that? Do you prefer SCT or not? Yeah. No. CDD, yeah, okay, good. A nice generic, non-specific attention problem, right? Yes. Yeah. Yeah, maybe. You know, on the one hand, you hate to see that. On the other hand, that's not a bad thing because if you were in public health, you would want the public learning about another disorder. Yeah. So what happened with ADHD is, you know, in 1991, when Hallowell wrote Driven to Distraction, adult ADHD hit the planet. And by the way, we had been studying adult ADHD since 1976. Nobody gave a damn until that book became a bestseller. So, you know, the point is well taken. Did that lead to overdiagnosis and too many people thinking they had the disorder and self-diagnosing? A little bit, but overall it was a good thing. Increased public awareness is a good thing. So maybe that will happen with this disorder. Yes, ma'am. Well, as I said, we found a little bit of memory problem linking to SCT. It was mainly in verbal working memory, what you might call short-term memory. They had a little trouble holding things in mind. But again, you have to stop and ask yourself, if this is a mind-wandering problem, then the problem they have isn't with working memory. It's the fact that they're using their working memory to think about other things. Whereas ADHD is a primary deficit in working memory, not secondary. So I think we have to work that out. Is the short-term memory secondary or primary? And I wonder. Yeah. None. I would say none. The closest I would come to is what she spoke about in terms of processing speed. But even ADHD children can struggle with that as well. So at the moment, we have no test that would differentiate these two disorders. It's going to be symptoms, pattern, history, comorbidity, and so on. But if you have somebody who comes to your clinic because of inattentiveness, but they're talking about a child who is quiet, reserved, a little socially apprehensive, stares a lot, daydreams, no impulsiveness, no self-regulation problems, this is the kid you're looking for right here. But you don't need to give a test to help differentiate them. Remember, the tests don't do well for ADHD either. We have no tests for ADHD. And the executive test turned out to be a disaster. Forgetfulness tracks more with ADHD than with this disorder. Now, parents will tell you this kid doesn't get his work done, but it isn't because he knew to do it and forgot to do it. This is a kid who isn't even concentrating on what you're saying. He's just not there. So you'll say something and, Steve, did you hear me? I said, it's time to get your work done. Earth to Steve, hello in there. And you'll see them shake their head. Oh, were you talking to me? Right. So it's that kind of, it's almost like they have trouble prioritizing what they're thinking about, and they're just not connected to the world around them quite to the degree that they should be. Some kind of disengagement from external events, but I'm not sure. I mean, you could get forgetfulness from that, but once again, we come back to the issue of, is it primary or secondary? And I don't know. Absolutely fascinating. So here's my summary slide. We've already talked about these things. I'm not going to go over them. Just take any questions that you have. Yes? Yes, I can. Wonderful, good friend of mine. She's writing the chapter on social skills. Actually, she wrote it from my handbook. Her name is Amori, A-M-O-R-I. Mikami, M-I-K-A-M-I. And you can Google her. But by the way, go to Google Scholar. Don't use Google, because Scholar will bring up all the scientific articles. Okay. And you can find, she's at the University of British Columbia in the psychology department, so you could write to her for more information. I will tell you, however, that when I've sent other people to her, she's telling them they're not releasing their training manuals until after their research is done. She's afraid of being accused of what happened with sensory integration training and CAPD. A fad got started and everybody started doing this stuff, like Mel Levine's One Mind at a Time school curriculum was never tested in any kind of controlled way, and got out there and then they had to backtrack because it turned out the evidence didn't back it up at all. It's like CogMed. It's out there and the evidence coming forward is more and more scathing that these things don't do what they're supposed to do, and she is very fearful of that. Yeah. Yeah. Good. Good. Yeah. Well, I would just talk to her. Maybe she's developing a list of people that she'll eventually send this out to. Maybe you can work your magic with her and soften her up a little bit. But I also understand that she really wants to make sure she has the science behind the therapy before she releases it clinically and starts recommending it. So that's... Oh, yeah, that's right. They got to have lunch, don't they? Yeah. Yeah, sorry about that. So it is now 12:45, right? Yeah. So you're supposed to have lunch, right? Thank you so much. I'll be around this afternoon. Sure.
So now I'm doing an evaluation and I've made this, I've decided that this is what's going on.
Right. Okay.
Okay, but it doesn't, can I just make it, I can't. What
No.
do I do?
You're going to have to go over and probably use an ADHD diagnosis, inattentive presentation, parentheses, right, SCT or CDD, and then describe it, because you want to signal to the people getting your report, this is not garden variety ADHD. Okay. You're going to have to play the insurance game of ticking the box for ADHD inattentive. Right, that's right, because this is not an official diagnosis in a taxonomy yet. Okay. So you guys are way ahead of the curve. You know more than even the DSM people know. So, yeah. Okay. Well, at this point, there's almost no evidence that we have to advise teachers of what to do, other than Pfeiffer's study that said All those things we do for ADHD help these kids. Token systems, daily report cards, checklists, ways of, little note cards on your desk to remind you of what you're supposed to be doing. But they targeted the daydreaming, the poor processing, the social shyness, rather than aggression, disruption, distractibility. It was just a matter of what were you targeting with your reinforcement programs and contingency management and your reminders and your charts. You were targeting their symptoms. So that's the most I would tell you. There's not like there's anything new here. It's just a different focus of the same stuff that we were doing before. More structure, but structure around the person to keep them engaged mentally with the task at hand. That's about the best you can do at this point. Yeah, be right with you. Oh. Oh. Thank you. Thank you. Yeah. 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 Thank you. Yeah. Yeah. Mm-hmm. Yes. Mm-hmm. Yeah. I agree with you. Yeah. Well, we're trying through presentations like this, through my website. Yeah. 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 Yes, it is. I would say certainly there's some negligence, and I think in the case of certain, like using MRIs or SPECT scans, it would be tantamount to negligence because we know that those don't work. There's something, just as an aside, my colleagues don't like doing what we're doing here today. My colleagues don't want to write trade books. In fact, if you write a trade book, it's a mark against you for promotion because you have stooped to deal with the public when you should have stayed within the ivory tower, doing your controlled studies, getting your federal research dollars. They don't esteem dealing with the public and the trade literature. Trade books, as far as they're concerned, are a waste of time. And I disagree with them. I have had this fight for 35 years of my career. Yeah, well, thank you. But trade books to me are more valuable than the damn textbooks that we do because they get the word out. They disseminate science. One of my heroes was Carl Sagan, the other is Richard Dawkins, and the third was Jacob Bronowski, the guy who did The Ascent of Man. All three went against their colleagues and went out and disseminated science to the trade population. Yeah, thanks. Well, you're so kind to say so. Thanks so much. You all enjoy your lunch. I'll take a couple of questions here, and then we're going to go.